Yes. Yeah, good evening, friends. Today is the next episode of Oncology Talks. May I request everybody to please mute their mics. Today we have Dr. Bhawna Sirohi again with us to talk about an interesting topic of managing low and mid-rectal cancer, T3 and beyond. Dr. Bhawna Sirohi, you know her. She has been a good friend and a consultant in Max Healthcare. She's been she has had a very good experience and a long experience of working with the best institutes in the world here in UK as well as in India. Over to you, Bhavna. Please start your talk. Once you're done with your talk, we will take the question and answers. Till then, everybody, please keep your mics on mute and put your questions in the chat box. Thank you.
Thank you, Padmaj, and thank you for inviting me to do this talk. I think this is my third one in this session, and I'm just going to talk about rectal cancer, treating low and mid-rectal cancers, T3 and beyond. So when we assess rectal cancer, what we look for is the depth of invasion, whether the lymph nodes are involved, whether there is extramural vascular invasion. That actually in rectal cancer may be more important than nodal involvement. Is the circumferential resection margin threatened? Is it possible, especially in low or mid-rectal cancer patients, is it possible to do sphincter preservation or organ-preserving surgery, which is actually an endpoint in quite a few clinical trials that we are doing now? Could you please mute your and plus, what type of surgery should the patient have? Just briefly to tell you, there are various levels, ways which we assess how far the tumor is from the anal verge, and you have various methodologies. And I feel MRI is the most accurate. So up to 8 centimeters would be low and mid-rectal cancers. As we discussed, the circumferential resection margin is very important, and this has been shown prospectively by the Mercury group. And I had the pleasure of working with Gina Brown and doing the MDTs with her at the Royal Marsden. Data on more than 17,000 patients showed that if you have CRM positivity, that is linked to not only loco-regional recurrence, but also to distant metastasis and survival as shown in the MRC trial. So what distant CRM is safe? Whether 2 millimeter, as you can see on this slide, is it safe or is it involved? And Professor Brown has shown that only 1 millimeter cutoff on the MRI predicts for local recurrence. And you can see the blue line is the 1 millimeter cutoff on the MRI. That's the distance that predicts for local recurrence. So very important, I can't stress it enough. Find a good radiologist, make sure that the patient with rectal cancer has an MRI done with the proper methodology. This has been published by Dr. Suprita Arya for Indian patients as well, and Gina Brown worldwide, she's led this. High-risk features, there are 2 trials which talk about the tumor within 1 or 2 millimeter beyond the MRF or the CRM. T3 low-lying tumor at or below the letters or less than 6 centimeters from the anal verge, and T4 and N2 tumors. Can we identify potential CRM positivity? Yes, we can. With the help of an MRI, you can actually talk about, we talk about neoadjuvant pathology staging as YP. So you can also talk about MR staging as YMR. So, or MR low rectal cancer surgical plane can be identified as unsafe, or if there is invasion of the anterior quadrant of the rectum, less than 4 or EMBI. If a patient has all of the above, the chances of the CRM being positive is 60%, which is linked to a very high incidence of local recurrence. I would encourage you all to read this paper. So all the slides are shared with you, and all of them have the papers from where I've taken the information on. So if you need any of those papers, you can ask me or Dr. Padmaj Kulkarni. So indications for neoadjuvant therapy, I'm not going to go through this in detail, but these are the broad indications. The extension to pelvic sidewall or lymph nodes, T4, N2 disease, or I've also put surgeon's learning curve and the desire to do sphincter preserving surgery as one of the indications for neoadjuvant therapy. Selecting patients is very important, as we do with all cancers, toxicity versus efficacy. We'll talk about this today, and the risk to benefit ratio. When you've done oncology as long as I have, and you will notice long-term side effects. We will talk about short course radiotherapy, high dose of radiotherapy, and chemo as well. So the long-term side effects which affect a patient's quality of life quite significantly are unintentional release of stools, stool incontinence, sexual function, which is very important for quality of life, anal blood loss, stricture at an anastomotic site, femoral head fractures, second cancers, and neuropathy. We used to do a proctitis clinic, I remember, at the Marsden with one of our gastroenterologists, Jarvis Andreev, because all the patients who'd had short course radiotherapy 10 years ago, 11 years ago, were presenting with proctitis. On the other hand, you look at efficacy, whether pathological complete response does lead to better survival. Again, I've said it before, for a patient, only two things matter: a better quality of life and living longer. So whether any of these trials we discuss leads to a better overall survival. And of course, sphincter preservation is also very important for quality of life. Sorry, I don't know what I did. Okay, so moving on to the next slide. So we'll talk about pre versus post-op radiotherapy. I'll just talk you through very briefly as to how we've come to today. So this was the German trial which randomized resectable rectal cancer patients to chemoradiotherapy preoperatively versus postoperatively. And the primary endpoint was overall survival. And the Dutch TME trial looked also at resectable patients, where patients had short course radiotherapy followed by surgery versus upfront surgery, and the primary endpoint was local control. Basically, this was long course, and the Dutch trial was short course. And as you can see, both of these trials show a significantly lower local recurrence with preoperative chemoradiotherapy. That's why it is very important when you see a patient with rectal cancer, a CT scan. Most patients will come to you with a PET CT scan or a CT scan of chest, abdomen, pelvis. I would still suggest that you do an MRI pelvis, because it makes a huge difference whether you give them preoperative radiotherapy or postoperative chemoradiotherapy. The local recurrence was significantly less with preoperative chemoradiotherapy. And in the German trial, which is the only trial which has shown statistically significant increase in sphincter preservation in those who received pre-op chemoradiotherapy. As far as overall survival is concerned, as you can see, the disease-free survival and overall survival was not significantly different in both the German and the Dutch trial. Coming on to short versus long course radiotherapy, again, these two trials have looked at this in mainly T3 tumors. As you can see, there is no difference in local control or overall survival. And even in sphincter preservation, as you can see, between short course and long course, even though the pathological complete response was 15% with long course, and with short course it was 1%. Remember, the surgery was done within 7 to 10 days after short course radiotherapy. The results of APR means most of these patients would have a stoma was pretty similar. Now, so I think we know that preoperative radiotherapy is something we should go for if a patient is going to need radiotherapy. Then the next question is it safe to delay surgery post short course chemoradiotherapy? So this was the Swedish trial, which randomized resectable patients into short course radiotherapy followed by immediate surgery versus short course followed by delayed surgery versus long course chemoradiotherapy followed by delayed surgery. And as you can see, the curves are literally on top of each other. So basically, this trial has shown us that even if a patient has short course radiotherapy, it is safe to delay the surgery. Now, the next question we have, I think the rectal cancer group worldwide globally has gone in a very systematic manner in trying to answer these questions at different places. So can we intensify the chemotherapy given with radiotherapy? You know that capecitabine or 5-FU works as a radiosensitizer, and the next question is, can we add something, very likely oxaliplatin, to 5-FU or capecitabine and see if it increases the efficacy? And there were 4 randomized trials which actually have shown that adding oxaliplatin difference at all. So it doesn't improve outcomes. By that I mean it does not improve pathological complete response rates. I think from 2004, neoadjuvant chemoradiotherapy becomes standard of care. Then 2012, we find out that capecitabine is non-inferior to 5-FU. In fact, there are a few papers which show that capecitabine may be slightly better than 5-FU to give with the radiotherapy. And now we no longer give doublet along with the long course chemoradiotherapy. So the next question we have is, what is the appropriate interval after the treatment is completed to assess response? So we normally tend to assess response after a patient has had radiotherapy 6 to 8 weeks later. It is said that the fibrosis is more if you delay the assessment and surgery to more than 11 weeks. But again, a lot of papers have busted that myth, and that is not the case. Surgery is not technically difficult, as the surgeons would tell you. So this trial was multi-center, randomized, and looked at the interval between 7 and 11 weeks. And basically, this showed that there is no difference in pathological complete response rates between 7 weeks and 11 weeks. But the patients who were in the 11-week group had more medical complications and a worse rate of complete TMEs. So I think the quality of TME, the transmesorectal excision, is very important, and a pathologist can photograph. I haven't put all of those in just for paucity of time, but I'm doing another lecture on Saturday for residents at 6 p.m. and we can discuss it at that time. From TMH, we published in 110 patients, 8 weeks, more than 8 patients who got operated within 8 weeks or after more than 8 weeks. And as you can see from this, that those who were operated more than 8 weeks later had a numerically more higher rate of pathological complete response, but it was not significantly different. And also the survival curves were on top of each other. So I think with all these trials with preoperative radiotherapy and chemotherapy, the local recurrence rate is between 5 to 8% in most of the trials. So we've become good at decreasing the incidence of local recurrence from 20% to below, I would say, 5 to 6% with the current regimens. But the rate of distant metastasis remains the same. It remains between 20 and 35%, which is quite high. Hence, the survival curves are not different with whatever strategies we've employed. So that's where we come to total neoadjuvant therapy. And I'll talk to you about this because we've had 3 exciting orals at ASCO this year talking about total neoadjuvant therapy. So you want to do it to see whether we can avoid adjuvant chemotherapy, because from various papers, you would know that from these 2 studies, 43% and almost 60%. And there's one paper where 70% patients actually do not end up having an adjuvant chemotherapy. And we know that every 4-week delay in adjuvant treatment actually there is no benefit in survival. And after 12 weeks, there is no benefit. Ideally, adjuvant chemo should start within 8 weeks of surgery, preferably within 4 weeks. So again, also to treat micrometastasis early. The second is whether we can avoid surgery, because nobody wants to live with a stoma, which does affect quality of life. And also, I talked to you about the long-term side effects of radiotherapy, which are quite significant. Can we avoid chemoradiotherapy, which is a lot of morbidity associated with pelvic radiotherapy, and also decrease the interval from ileostomy to reversal of stoma? So with TNT, I'll call it TNT, total neoadjuvant therapy. You can have chemo first, or you can have radiotherapy first. So these are the various phase 2 studies that have been done. I was part of the expert trial where we recruited patients with Professor Cunningham. And I'll discuss some of these trials very briefly before we move on to the ASCO presentations this year. So the tumor response, the Spanish trial was the timing trial, which had all the patients had long course chemoradiotherapy, and there were 4 cohorts. So the first one, the patients just had chemoradiotherapy and proceeded to surgery. Interval to surgery was 8 weeks. Then the second cohort, they had 2 cycles, 4 cycles versus 6 cycles of FOLFOX. And as you can see, the interval to surgery has gone up. Also, you can see in the third row that the pathological complete response has gone up from 18% to 38%. The only other study which actually showed that the pathological complete response was 36% was the AVACROSS trial, where patients had capecitabine, oxaliplatin, and had bevacizumab added to it. But that has never taken on because the rate of surgical morbidity and the complications was quite high in that study. So that is also something which we don't want to do. So you have to balance the risks with the benefit to the patient. So as you can see, as you increase the interval, the rate of pathological complete response has increased in this Spanish study. In this Polish study was very high risk patients, and this is almost replicated by the Rapido trial that we will discuss presented at ASCO. Most of these patients had a T3, T4 or locally recurrent rectal cancer, were randomized to short course followed by FOLFOX. So we know that it is possible to delay short course. After short course, it's safe to delay surgery. So what we are trying to do is fit in chemotherapy in that delay. So the patients had 6 weeks of FOLFOX and also long course. The second arm was long course chemoradiotherapy. The primary endpoint was an R0 resection. And as you can see, that with the long course, the toxicity was significantly higher compared to short course and FOLFOX, but the R0 resection rates were pretty similar. In fact, numerically slightly higher in the short course arm. Pathological complete response rates were also not significantly different between short course and long course. So the Spanish randomized trial, this is chemo first. So we've talked about radiotherapy first, total neoadjuvant therapy. Now we'll talk about chemotherapy first. And this was a phase 2 study where patients had long course chemoradiotherapy versus CAPOX times 4, followed by long course, followed by surgery. The total duration of treatment in this trial was 6 months. And as you can see, that with total neoadjuvant therapy, there was greater compliance to chemotherapy, 94% versus 57%, but there was increased toxicity and less toxicity with CAPOX times 4 followed by long course chemoradiotherapy. So better compliance and less toxicity with total neoadjuvant therapy. So I think the current paradigm is it used to be chemorad followed by surgery followed by chemotherapy. But like I said, 25 to 70% do not actually end up receiving systemic chemotherapy. And this is the same story in pancreatic cancer as well. So we are trying to shift the chemotherapy in resectable patients upfront before they have chemoradiotherapy. So again, like I said, you can have two approaches. The terminology that you will hear a lot is induction is when you give chemo first, and consolidation is when you give chemo after chemoradiotherapy. Neoadjuvant alone, chemotherapy alone as an alternative to radiotherapy. I think that there was a Chinese trial published a couple of years ago with FOLFOX, which showed good better pathological complete response rate with neoadjuvant chemotherapy, but there was no disease-free survival or overall survival benefit. I think all of us are eagerly awaiting the results of the PROSPECT trial, which is led by the Alliance Group in US. Preliminary data was presented, which showed that the PathCR is about 25%, but I think we still need to see the full data. So coming on to the trials that were, some of these are practice-changing trials presented at ASCO this year. Rapido is, again, you can see T4 patients, EMVI positive, N2, CRM positive. So very much like the Polish 2 trial, were randomized to short course followed by CAPOX times 6 versus long course chemoradiotherapy with capecitabine followed by TME. And the primary endpoint was time to disease-related treatment failure. In the same breath, I'd like to discuss the PRODIGE trial, which was also presented at ASCO, which looked at T3, T4. Again, you can see this is short course and this is long course. Patients received FOLFIRINOX or FOLFOXIRI, which is colorectal, no bolus 5-FU, followed by long course chemoradiotherapy versus long course chemoradiotherapy followed by TME. And they also had adjuvant chemo for 6 months. As you can see in the short course study, the Rapido study, that there was a significantly better pathological complete response rate, almost double, 14% versus 28%. The primary endpoint, 3-year disease-related treatment failure, was significantly better, 24% versus 30%. And the probability of distant metastasis was also lower in the short course followed by the chemotherapy arm. So the study did meet its primary endpoint. If you look at the Polish 2 study and the Rapido trial, the pathological complete response is slightly higher, but again, the interval to surgery was also double, 11 weeks versus almost 22 to 24 weeks, and more cycles of chemotherapy in between. PRODIGE-23 was a long course chemoradiotherapy, and FOLFOXIRI was the treatment that was given. Again, with neoadjuvant chemotherapy, the disease-free survival was significantly better. The metastasis-free survival was significantly better. Pathological CR rate was better. But sadly, none of these trials actually show a difference in overall survival. Now, coming on to the next question about the sequencing, whether you give chemo first or you give radiotherapy first. This is a small trial with good risk patients, as you can see. They're stage T3-4 node negative or NET node positive. CRM was not involved. EMVI was not assessed in any of these patients. Randomized to FOLFOX followed by chemoradiotherapy, FOLFOX 8 cycles or CAPOX 5 cycles, versus chemoradiotherapy followed by the same regimen, followed by TME or a non-operative strategy. Basically, one of the primary endpoint was 3-year disease-free survival, and also whether it is possible to organ preserve in rectal cancer. So another trial which was published last year, this German study also was pretty similar, where patients had 3 cycles of FOLFOX followed by long course versus long course followed by FOLFOX. So very similar, but as you can see, the trials are slightly different. Here, the primary endpoint was PathCR. The intensity of oxali was different, 85 per meter square versus 100 per meter square. Duration was different. Doses of radiation were different. So it is not possible to compare these trials head to head. The interval from end of chemoradiotherapy to surgery was about 45 days versus 90 days in the trial. So if you look at the pathological complete response in the German trial, it was slightly higher with chemoradiotherapy followed by chemotherapy. The organ preservation was higher in patients who had chemoradiotherapy first followed by chemotherapy. So my radiation oncology colleagues would conclude that upfront, and I think this is fair, but these are small trials with small numbers and not bad risk patients, is upfront chemoradiotherapy followed by chemo appears better than the reverse sequencing in neoadjuvant therapy. We did talk about toxicity of radiotherapy, and I think it's very important. I would like to reiterate that the MRC trial showed that at 2 years, the unintentional release of stools was 52%, a high in patients who had long course chemoradiotherapy. It impacted male sexual function, higher fecal incontinence, and risk of second cancers was 1.8 times higher in patients who had radiotherapy. So these are, and as we are seeing, at least in quite a few of my patients in India, I'm seeing quite a few of our patients are presenting young. And so we are looking at not 10 years, 20 years life expectancy, but we're looking at a life expectancy that's going to span for more than 20 or 30 years. So all of these side effects, which come quite a while later, become very important for a patient's quality of life. So prospect is this trial. I will not go into the details because I don't have the detailed slides on this. But this is patients who respond. Patients are randomized to 6 cycles of FOLFOX, followed by TME if they have a good response. If they don't have a good response, they end up having long course chemoradiotherapy anyway. And the standard arm is long course chemoradiotherapy followed by TME. So this trial has completed recruitment and the data is maturing. Hopefully we'll hear about it in the next few years. So I think it's to deliver the best in rectal cancer care, very important that you have the right protocol and have a high quality MRI scan, and you have a synoptic reporting template, which has EMVI, the distance from the anal verge and the nodes, all of these variables into it. And also have another synoptic template for reporting after patients have had chemoradiotherapy. Also, surgeons who perform high quality TME, it's important to know the local recurrence rate because the quality of TME is very important. And pathologists who photograph and score the specimens, because a pathologist will be able to tell you about the quality of TME. If the CRM is threatened, pre-op treatment is indicated. EMVI is also a very good marker. Short course and long course, based on the data that we currently have today, are both equally acceptable. And short course followed by consolidation chemo is also, as you saw from the Polish 2 and the Rapido studies, are acceptable. Neoadjuvant chemotherapy does impact disease-free survival, pathological complete response rate, which actually leads to a sphincter preservation and metastatic and better, less number of metastasis. But none of these trials to date have shown that they impact overall survival. I think more chemo in longer interval may lead to better response. But again, the question is which chemo? I have tried to give FOLFOXIRI in patients who have an ugly tumor after they've had chemoradiotherapy. The CRM is still threatened, and we end up giving FOLFIRINOX or FOLFOXIRI. And because of the pelvic, possibly because of the pelvic bone marrow being radiated, FOLFOXIRI is quite a difficult regimen to give anyway. But the risk of neutropenia and thrombocytopenia is quite significant. So I feel that if I have a patient with a bad or an ugly tumor, as defined in the ESMO guidelines, I would actually prefer to give chemo first and followed by chemoradiotherapy, followed by a decent interval, followed by surgery. I would like to acknowledge Gina and Rob, from whom I borrowed some slides. Thank you. So do we have questions?
Yeah, thank you very much, Bhawna. It was, again, a wonderful talk last time. We have a couple of questions, I suppose. The first question is, considering the recent evidence, what TNT approach to use in clinical practice? SCRT, more than LCRT, or LCRT with followed by 3 drugs. How to choose between these three different approaches?
So, when you have, I think in clinic, if you see a patient with rectal cancer, especially if it's a low rectal cancer, patients are very symptomatic. And what I have seen is if I give them just one cycle of Folfox, within a few days, I would say within a week, there is immediate relief of symptoms in majority of patients, I would say. So, and in that situation, if you give radiotherapy, I feel it actually exacerbates the symptoms, and especially if they end up having skin toxicity as well. So, practically, I feel we have evidence to give neoadjuvant chemotherapy with the PRODIGE data that you can give folfoxiri or Folfox for that matter, followed by long course or short course chemoradiotherapy. And in quite a few of our patients, we have to individualize the treatment. So my preference is to give chemotherapy followed by chemoradiotherapy. And I would go for chemotherapy followed by short course actually, if a patient is elderly. Right now, unless we have long-term data with short course, it's very difficult to change practice completely to short course.
What do you prefer in the current COVID era? What are your choices?
So in the current COVID era, I would prefer short course radiotherapy. And because what we want to do is decrease the footfall of the patient to the hospital. And in most of the patients, actually, we've started them on neoadjuvant chemotherapy. And now they've come up to chemoradiotherapy. And we would prefer to give short course because there is no evidence, like I showed you the two major trials, that long course adds any further benefit to short course chemoradiotherapy. Short term, yeah.
I think, yeah, right. I think I tend to follow same what you said because when the patient come in, they have significant complaints of constipation and passing
Yes.
stools. And when you start concurrent chemoradiation, they are in a lot more trouble.
Yes, absolutely.
So yeah, it does help to give them a couple of cycles of chemotherapy to give symptomatic relief. That's what they are worried about, and then you move on to the radiotherapy. I think that's a very pragmatic, practical approach.
Yeah.
I think the next question is choosing between Folfox versus Capox in neoadjuvant therapy.
So again, I think we have had this discussion before. So I would prefer to go with the Folfox to maintain the dose intensity in our patients because it is very difficult to give capecitabine 1,250 milligrams per meter square. But if there are like these days with financial issues, during COVID times, I've switched most of my Folfoxes to Capox because with Folfox, they have to come for the pump removal. If they have a PICC line, they have to come for weekly flushes. So we are tending to put chemo ports or, just do Capox through a peripheral cannula. And so these days, I'm preferring to give Capox, though I may have to reduce the dose slightly of capecitabine in some of my patients.
Yeah, I think that sounds quite appropriate in this current era.
Yeah.
The next is how to choose patients with FDG with retroperitoneal nodes.
So again, I would give so we recently had a patient, sometimes it's very difficult to biopsy the node. And in our setting, we should also have tuberculosis in mind as well. So if it is possible to define intent, I would suggest we try and FNA the node if it is possible at all. If it is not possible at all, I would give benefit of doubt and treat patient with the radical intent. But usually we are able to come to some decision within the MDT with the MRI and the FDG PET if we discuss in the MDT with the nuclear medicine and the radiologist combined.
Absolutely. The next question, what percentage of patients remain inoperable after TNT?
So I think most of these studies have talked about the studies I presented. I would say about no response is seen in about 20% patients. But this is, we are talking of really signature histology, very locally advanced patients who to begin with would have been candidates for APR. So I would say 20% patients do not respond to the treatment. And there are some patients who actually progress on the treatment. I recently had a young patient, a very young patient who progressed after chemoradiotherapy, and then we gave FOLFIRINOX to try and see if we can control the disease. It had signature histology, and unfortunately, he responded amazingly well to 3 cycles with the CA dropping down to normal. But he immediately progressed. The day he went to Tata for surgery, and on the day of surgery, I was called that he had ascites. So again, signaturing patients, which we see more of in India, I think our data is going to be worse than the Western data. That the chances of non-responders, my feeling is it will be 20 to 30%.
Yeah, if they don't respond, they can go for concurrent chemoradiation, probably.
Yes.
Yeah, but they if they progress, what is your choice? What do you plan for them?
So like this gentleman, we gave FOLFIRINOX, FOLFOXIRI, and but otherwise, if it's just local progression, it's APR, sadly, for local control. If there is no systemic disease, yeah.
Right. The next question is about TNT. Is it an acceptable approach for patients with sphincter involvement?
Yes, I mean, it's actually the right approach to give patients. I would prefer to give such patients neoadjuvant chemotherapy first. And because again, the fecal incontinence is quite marked in these patients, and there is a lot of anal spasm, a lot of pain. So sometimes we do a ganglion block as well, and a diversion stoma before we start the treatment, because again, every time patients pass a stool, it's a complete, it's quite challenging. So in these patients, I would actually suggest doing a diversion stoma and then start chemotherapy followed by chemoradiotherapy.
Right. The next question is, why is delaying surgery post-RT, why does it result in high path CR? Any scientific reason?
I think our radiation oncology colleagues would tell more, but it's again the effect of radiation is it's to do with the biology and the cell cycle. The fibrosis is more the further you get away from radiotherapy, and so even in most of the radiotherapy treatments that we give for pain control, we always tell the patient the maximum response will be in 4 to 6 weeks. So
That's
yeah.
right.
Yeah.
That's right. Sharda has asked a question, after SCRT or LCRT, if node positive, do you give adjuvant chemotherapy and what regimen?
So yeah, I mean, I think I always go by the preoperative staging. So even if a patient has had a PAT CR, and we did a debate whether they actually need adjuvant chemotherapy. And for adjuvant chemotherapy in rectal cancer, if you look at all the guidelines, they have extrapolated from colon cancer. So there is no randomized trial per se in rectal cancer. Most of the trials have actually been about organ preservation, sphincter preservation, PAT CR, or watch and wait strategy. So I would give adjuvant chemotherapy, and what I normally tend to follow a thumb rule is if I've given 3 months of neoadjuvant chemo, I would give 3 months of adjuvant chemo. Or if they've had no neoadjuvant chemo, I would give 6 months of adjuvant chemo if they're node positive. Yeah. So basically 6 months of chemo that they get.
Right. Should standard 6 months of perioperative chemotherapy not include pre-op and post-op duration? I think
yes.
That's what we just talked about.
That's what we said. Yeah.
Yeah, it's sandwiching RT a better strategy for ugly rectal tumor to FOLFOX, followed by LCCRT, followed by FOLFOX, followed by surgery?
That's a good question. There is no data on it.
Yeah,
So
we can't answer that.
we can't answer that. But yes, I mean, you can do anything, but there's no data on it. I would rather give chemo first, then chemo, radiotherapy, and then surgery. Yeah.
After chemo and SCPRT, how long to wait for surgery? For response assessment, how long you wait for?
So you are asking, so a patient has had, let's say, Kpox followed by short course radiotherapy.
Yes, yes, yes.
The trials waited for 6 weeks, I think. So 6 to 8 weeks after the end of radiotherapy to proceed with surgery.
I think that's right. If we compare SCRT versus LCCTRT, is LCCTRT is better to prevent LR. So, what is the indication for SCRT?
So if we compare short course versus long
Long
course.
course, long course is better to prevent local recurrences.
So no, there is no evidence to show that, head to head, all the trials that have compared long course to short course, as I showed, there is no evidence to show long course is better to prevent local recurrences. So that's what I was saying, that, you can actually safely. That's why for quite a few patients now in the COVID era, we have decided to go for short course, because actually head to head, there is no evidence that long course is better than short course.
Yes. Mm, any particular reason for younger age of presentation in India?
So I think our population matrix is young, and that could be one of the reasons. So for all cancers, you see that our median age is a decade younger than the Western population, whether it's breast cancer, prostate cancer, any of the cancers. And I am actually very surprised by seeing late 20s and 30-year-olds with rectal cancer, colorectal cancer. And I remember when I was in Tata, I mean, we saw some very young patients in their early 20s with signature histology, and most of them did quite badly. And so I've written up a questionnaire on this to see whether if we can identify any risk factors. I'm working with Dr. Rajesh Dikshit at Tata to see if we can look into some factors as to why so many young men. I didn't see so many young men in London of Asian origin, so I'm surprised.
Yes. Any other question?
So we have to give 6 months of therapy, including NACT, surgery, and adjuvant, or adjuvant chemo is of 6 months. So I think what I meant was adjuvant chemo. So if you've given 3 months neoadjuvant chemo, I would give 3 months of So if you've given 6 cycles of FOLFOX, I would give 6 cycles of FOLFOX post-op.
I think people follow different practices. Some people consider the concurrent chemotherapy also while counting the 6 months of perioperative chemotherapy. But I think, 6 months is what, yeah.
So would you prefer an ugly rectal cancer? So, Kpox followed by chemoradiotherapy versus CTR. So, I would, for a young patient, I would actually give FOLFOXIRI, because you only get one chance at a cure. If it's a young PS01 patient, and as you know, with all the generics available, the cost is not too very high. And we've become very good from pancreatic cancer at dealing with the side effects. So I would give FOLFOXIRI, and then followed by chemoradiotherapy, followed by, at every stage you would do an MRI assessment actually, and look at the response. True. Yeah. And followed by CRT, followed by surgery 6 weeks later if it's long course.
Well, there's an invitation for you to take a class on colorectal liver mets and different scenario.
Yeah, we could do that. And actually, we could do a case-based discussion as well with one of these, actually. That will be quite good.
Yeah, let's see. We've completely booked till November. So let's see where we can fit in. I mean,
okay. So, Patmaj, I do a weekly teaching for surgical, medical, radiation, all three groups on Saturdays, 6 to 7 p.m. Right. So this week is actually rectal. We just finished neuroendocrine in 2 weeks' time. We're going to do rectal in about 2 to 3 weeks. And then we'll take up colorectal liver mets. So, I mean, any of you are most welcome to join. You've got my email.
Yeah, people can join, those who are interested. Yeah, it will be good to have you with us sometime. ISNPO is again also going to start webinars on their website.
Okay.
It will be a different topic-based webinars. So we probably will have, say, one topic, say colorectal cancer, and then it would be an exhaustive kind of thing to cover most of the things which are required in that particular topic. While these talks, which are for students, these will be restricted to students only, so that there is very good interaction with the faculty, which may not happen in the ISMP webinar. So let's see how things go.
Okay.
Okay, thank you very much, Bhawna. It was nice to have you with us, and we'll meet next week with some other expert and some other talk. Thank you very much.
Thank you so much. Bye-bye. Bye.